Well, this is a strange one. I'm going to introduce myself because the next talk was given by me at the meeting. And in this talk, I speak about intravascular ultrasound and its value and use within the treatment of CCSVI. I'm pretty passionate about IVUS. I don't know how I could do this without it. So forgive me if I say this next talk is really great. Okay, so let me tell you how I got involved with intravascular ultrasound, which I believe is the quintessential component of this procedure that many people, including myself, have done the procedure without it and had positive outcome, but it's like doing it like this. You can open your door with your eyes shut, or you can open the door with your eyes open. I believe that IVUS opens your eyes. And there's nuances to treatment that I believe are completely dependent upon IVUS. Now, how did I get involved with IVUS? I was up in Toronto, in Hamilton, when there was a meeting that Heikki put on, and Zamboni was there, and I was about to treat my first patients, and I wanted to know, maybe I had already treated my first patient, yeah. So anyway, I went up there to talk to him, and I showed him some cases, and I said, what about this? And he said, oh, that's just because the vein is stenotic, so the vein above it is collapsed. Well, that's counterintuitive. If I got a blockage here, I would expect everything to go get larger, and instead it does sometimes it does the opposite, because there's a dual outflow. So if the vein in the front is supposed to be draining, and because there's a blockage here, everything's going down the other way, then there's less blood going into the one that's blocked. And if there's not enough volume in something, it collapses. And I said, thank you, Paolo, that makes a hell of a lot of sense to me. And I got back on the plane, I said, what the hell am I going to do now? How am I going to know whether it's real or not? I said, I got an idea. We built our procedure suite 5 years earlier, and I wanted all the toys I could at the first moment of, because you get a big package when you buy a $2 million unit. So you can add a few extra things and nobody notices. So I got an IVUS, and it sat in the closet for 5 years. And I said, I'm going to use the IVUS. And that was why I used the IVUS, because I had it. If I didn't have it, I wouldn't have figured it out. I probably would be still a skeptic right now. So that's how I got involved with IVUS. And I would say that I used IVUS in all the cases at the hospital. And then shortly after arriving at American Access, I tried 2 different IVUS. One was really like the one I used at the hospital, and the other one was like dog meat. And so there's a few cases where I really didn't use IVUS, but the overwhelming majority of patients that I've ever done this procedure on, right from the first case, I've used IVUS. Now, I didn't know what I was looking at when I first used the IVUS, but I used it in every case. And like eventually the light goes off in your head, you say, now I get it. So let me show you what I think of IVUS and give you some of the revelations that it's led me to. What we're going to do is review IVUS, what it is, illustrate stenosis analysis by IVUS, and then try to show a little bit of just a glimmer of how you can use IVUS to enhance the therapy. The IVUS is a real-time intraluminal ultrasound, so there's no gel, there's no pressure on the neck. The catheter has the ultrasound probe on it, is put in through the same puncture for the venogram and then positioned in the blood vessel. The ultrasound is turned on, it sends out a sound wave, it hits the wall of the vein or something else inside the lumen of the vein, and reverberates back and is received by the same device. It goes out through the wire that's attached to the unit. It goes into a black box. The black box does some calculations, and voila, you have a different kind of picture than either a surface ultrasound or a venogram at all. There is a couple of other devices. One is a probe that can measure blood flow and pressure. And there's another way to look at this with what they call chromaflow, which assigns a color to different characteristics of tissue. In the first year, I've focused completely on the image itself and not on these other parameters or devices. The unit costs about $120,000. Each catheter costs about $700. So it makes the procedure more costly. It increases the time of the procedure by about 30 to 40% in time. So it's time for the room, takes longer for all the people working in the room. So it's more expensive to use it. I believe it costs us more money than we charge for it. And it makes my procedure cost more than the going rate. But for me, I can't function any other way. As I showed before, there's a little device. It goes over the guide wire, and you can see that transducer is that tiny little thing. Any of you who've had an ultrasound, it's like this big thing. Now they've miniaturized it and allowed it to go through small guide wire and catheter. And what you do is you advance this probe up to the base of the skull at the top of the vessel, and you turn on the ultrasound, and it starts to record the reflections of the sound, and you pull the catheter down slowly and interrogate the entire jugular vein in a different way. And you get a completely different looking image. So what you see in the center image here is an ultrasound of an IVUS. The black area in the center is blood, flowing blood. The brighter area is the wall of the vein. And then there's the periphery, which are really not pertinent. If you could black them out, that would be okay. What you can see with this device are the collateral veins, the diameter of the vein, the cross-sectional area of the vein, and any material inside the vein. So you can, as you pull it down, you can see the cross-sectional area get smaller and bigger. And sometimes you have to differentiate what Paolo was telling me to do between low volume shrinkage and stenosis. So there are ways to increase flow by inspiration and expiration that will enable the vein to expand and contract. So if something's expanding and contracting, it can't really be a stenosis. On the right, you see a tracing in a different projection. Those are the reverberations off the wall of the vein. So we're at the top of the vein is at the top, and lower down is below, and you see the reflections off the wall of the vein. There's a lot of artifact in the middle, but I call your attention to this area here, which looks very different than the rest of the vein. This is abnormal tissue that doesn't belong there. It's supposed to look like this. Now, what is this? It's this. That's part of a valve that never opens. That diameter should be out here. So we have shrinkage, we have narrowing of the vein from that simple picture that you really sometimes can see and sometimes cannot see on standard procedure. Here's what it looks like in real time. And you can see the same thing I was talking about before, but here instead we see the vein with narrowing. Here's an edge of a valve that's trying to open and close. But this is the vein. And this is the valve. So the valve's not opening to accommodate the entire lumen of the vein. And that's right here, right here. That's the valve, the lumen valve. That's where the blood's flowing. But the vein is all the way out here, so you can see the vein is narrowed. Now we can take those images and stop them, and then we can measure the cross-sectional area of the valve area and compare it to the total volume, the cross-sectional area of the vein, and the computer will very nicely tell us that there's a 61% stenosis. Great accuracy that you can't do in venography. Another example. If you look at this vein is not a circle, it's an oval. So if your X-ray beam is going in this direction, you get to see this diameter. But if it's going in this direction, you see this diameter. You use that diameter to decide what balloon to use. Now, the difference here is the difference between a 13 millimeter and, is that 8? I can't really tell, 8 or 9 millimeters. So there's a big difference between those two diameters. So that you can't, you have to be really more accurate than picking a diameter of a balloon. Because the balloons dilate in a circle. So if you use the narrower component, you won't dilate the whole vein. And if you use the other diameter, you're going to overstretch the vein. So it's best to use this cross-sectional image to get an accurate measurement of the diameter of the measurements of the vein to get a better image, and then better treatment. This patient, by the way, had already been treated elsewhere. And you can see the nice stretching of the vein compared to the vein that wasn't stretched. Unfortunately, it didn't detect, that venogram did not detect the stenosis. The stenosis is down here because they couldn't see this valve. And I guarantee what happens is the contrast media comes down, it goes through here, through the narrowing, and then it refluxes back up and surrounds this whole area. And sometimes that looks totally normal. And so they missed the point of stenosis. I think IVUS is going to help that. Look at the difference here in this vein. Is it a 16 millimeter diameter balloon that you would use? Or is it a 12? That's a big difference in diameter. And it's an even bigger difference in cross-sectional area, because cross-sectional area is a square of the radius, right? So it's a big difference. Here we have a 70% stenosis. And here you're seeing the edges of the valve. The valve's not supposed to be like that. What the valve has done is elongated and fused itself. So it's forming a funnel. So it's hard to see for sure in all the cases, but in many cases you can tell that as you go up or down the vein, this area of valvular tissue that you see gets progressively smaller and smaller to a pinpoint. So that's what we see with IVUS. Again, another case. Here I've put it in real time so you could see what I call the double echo. And that's an echo bouncing off the valve and being detected, but sound also going through the valve, hitting the wall, and then bouncing back and being detected. So on this study, you see the valve leaflet and the wall. So it's a different way to look at this and make the diagnosis of valvular stenosis. There's a lot of advantage to this procedure. It's dynamic, so we can address those issues where we're worried about a physiological narrowing compared to a stenotic narrowing by watching the vein diameter expand and contract. It gives us all of the things we want, cross-sectional area. It doesn't radiate any additional stuff. There's no contrast media. I can do 500 reviews, and I don't go back and look at the same images over and over again. If I'm not sure of something, I'll just turn on a machine and do it again, because I'm not ionizing, radiating patients, and I can pinpoint the narrowest part in the vein, and then turn on the fluoroscope and say, that's the point where I got to blow up the balloon. It's really very good. So there's things like the hypovolemic collapses, compressions. There are these transient narrowings that may be related to movement or respiration. And then there are real narrowings, such as hypoplasia and pathological valves. And we have to be able to differentiate those. So let me see if I can do some of it quickly. Here is a case that on venogram, with the X-ray beam going in this direction, the jugular vein looks very narrow. Of course, you can't see the carotid artery that's compressing it like you can here. But when you take a deep breath, the carotid artery compression is still present over here, but the rest of the vein distends out away from the carotid artery. So we know that this is not anything that needs to be treated. And that's not an uncommon situation. For example, in this case, you're all budding interventionalists anyhow. So if you look here, again, you see those valves that I mentioned before. There's a stenotic, irregular, non-moving valve here, but we have narrowing here, another narrowing here. I mean, which one do you treat? Do you treat them all? I know that when I started, I would balloon those. There would never be a waste on the balloon. The balloon would expand fully with no pressure. It's muscle compression, or it's not real, because when you do inspiration and expiration, you can see this the same area of the vein collapsed and open. A balloon's not going to make this any better. So unless you're willing to put a stent in there, there's no treatment for it. Same thing with the azygos. Look at this azygos. You inject the azygos here, and all the flow goes down. Again, all the flow goes down. In fact, you do see the azygos, but it fills through retrograde reflux into this collateral. And then all of a sudden, this is what you see. This is the same area. It's totally normal. I don't believe that one should be stretching a vein that can stretch on its own. And IVUS, in that area, you can see it happen. You can see it open and expand and close. Now, I might be proved wrong someday. I'm leaving that option open. And if maybe this is important, I'm not sure. But here's what it looks like, that patient. Just follow this. I tell the patient to breathe in. That's an autoangioplasty, I guess. Sometimes you see stuff like this. A blind ending sac going nowhere. A septum in the vein. This septum is a false lumen here, and the true lumen is very narrow. You don't even see it here because the catheter went into this lumen. Now, these are very challenging because if you do a Valsalva maneuver, this will distend and completely obstruct the true lumen. It's really problematic. I treat them now by balloon dilating, but I can see coming to a point where there will be a day when the treatment's going to be to put catheters on either side of that and then make an incision to open that up so that the flow can just go in both directions. We already do that for dissections, for example. So dissections of the aorta. It's called a fenestration procedure. So, but you can't do that if you don't know which way your poker is going to go to cut this. You wouldn't want to cut the outer wall. You have to cut the inner wall, so you need to be able to see it. And you can't see this septum on a venogram. So here you see, this is what I was talking about before. You can see where the green arrow is. There's a very narrow lumen. This has no power. But the green arrow is pointing to a jet of contrast media going from the jugular vein to the innominate vein. Now, why is it there? If you look at the smaller IVUS at the bottom, with the curvy yellow arrows, that is the narrowed segment, that circular area surrounded by that. You can see how big the vein is. It's just here. That's the whole vein, but everything's funneling through this little space here. But once the contrast gets out, it goes back and fills the space over here. And I have been shown many, many venograms where this area right here was also filled with contrast media. And you just can't see that stenotic segment at all because it's washed back in and obscured the difference between the stenotic area and the area around it. But on IVUS, this is, pretty obvious. These are just different valves. You see, this is not supposed to be like this. The valve's supposed to open fully. This is just not opening. That's, as a wine lover, all I did was take 2 of my wine flasks, put them together, and illustrate for you what I'm seeing. This is the vein above. This is the vein coming from the brain. And this is the vein going to the heart. And imagine, if you will, that this part was fused here. But the valve elongated and fused. So you would end up with this part and this part connected to this. But if you put wine in here, it would go right down here. Now, but the way we inject it, it would come back and flow up this way. And then everything looks like wine. And you completely miss the stenosis. Happens all the time. People get better now, but it happens all the time. Now, this is an illustration of the use of IVUS in therapy. Let me see if I can do it. Somehow that's supposed to... Yeah, thank you. Put it on. You missed it. Double click it maybe? Bring it down. Not working? Just do me a favor, it's got to work. Double click on the image itself. Maybe that'll work. Pity. Okay, well, let's not belabor it. There is a valve. You can sort of see on this area. This is valve. The valve never quite opens. And you can't even see that this slight narrowing that you see here is only part of the story. There's a jet coming right down the middle, and the contrast is flowing back up on the around it, so that you really almost completely obscure that stenosis. So we treated it. And if you look at the treatment images, now you see the valve that I couldn't show you before. This looks pretty good, right, on the left? But if you look carefully at the IVUS, you can see that the valve right there is not opened all the way, right? If you look carefully at the image on the right where the arrows are, you can see the double density of the stenotic area and the contrast on the outside that's filled up around it. These are the same images, just manipulated a bit to show that better. So if you look at that on the side, everybody says, great job. IVUS tells you you're not done. So we put in a bigger balloon. And now look at the vein. Completely opened. So IVUS makes that happen. It's hard to see that otherwise. Otherwise, you just underdilate the veins. That we talked about. So, I mean, I think what IVUS has shown me is, without a question, the majority of the problem that we see are valvular stenoses. They're either fusion of the valve leaflets together or malformation of the valve so that it forms this funnel-like appearance. And that's what we really need to treat most of the time. So think about it. We don't have to overdilate a scarred vein to stretch it open. And when we stretch scar tears. When scar tears, it leads to more scar. So what we want to do now is stretch open that internal valvular problem without overstretching the outside part of the vein. Because I believe that in most cases, the outside part of the vein is normal. It's an interior problem. Of course, there are valvular stenoses, then there are hypoplastic stenoses. Hypoplasia is a different entity, different prognosis. It will lead to scar tissue in the vein when you overdilate it, which you necessarily have to do if you're going to try to treat those. There's a variety of other things. So I'm not saying everything that we see here in this disease is valves, but it sure is mostly. So I'm not going to give you too much, because then I won't have anything to say tomorrow when I teach my guys.